Good afternoon, everyone. Welcome to our member webinar for the National Association of State DD Directors. We'll be talking today about national scan of Medicaid managed care practices for individuals with intellectual and developmental disabilities. As we are getting folks in the room and connected, we'll be starting in just a moment. Mary, it looks like the attendees has slowed down a little bit. So if you want to get going, I think we're ready.
Thank you all so much for joining us today for this webinar. As Taya said, we are really pleased to be able to share with you the results of a national scan on Medicaid managed care practices for people with IDD. I want to start by thanking Karen Kimsey and Taya Stokes and Janine Zalaki on our team. Karen's been gracious enough to join us in partnership to work on this really important body of work aimed at identifying both best practices, but also potential opportunities for improvement in helping state IDD directors engage with state Medicaid agencies and with health plans in your state in the spirit of really providing truly person-centered supports and services for individuals with IDD. We talk a lot in our systems about that notion of person-centeredness, but we've got some opportunities to really build better partnerships with healthcare and behavioral health care to make sure that people with IDD have access to a real fulsome set of services and supports that recognizes their whole person. We often think myopically about the disability, recognizing that really folks are made up in multifaceted ways and that we've got opportunities in partnership with health plans, with the medical community, with our state Medicaid partners, with behavioral health clinicians and others to make sure that we are really leaning in together to make sure folks have optimal outcomes and to really think about their whole person. And in addition to it being a good for the people that we support, it actually is a really important thing to think about as we're looking to make sure that the resources are going to the exact right spot. We've got precious and limited resources in our system, and we want to make sure that by taking a zoomed out approach, we can really see how best to support people, perhaps avoiding crisis wherever possible, or more complex medical conditions that might impact their long-term services and support. So it's a little bit of my pitch, but I'm going to turn it over to the expert to really help us see the opportunities. And just as a promise, we really are hoping to continue this effort and to build some partnerships with plans so that we can understand some of those better practices as well. So thank you so much, Karen, please.
Oh, thank you, Mary, and thank you, everybody. And it's so exciting to be here to talk with you all today about this really, really important topic. And we'll move into the next slides. I think Mary just wanted to, and also just to highlight and to say what an amazing team at Taya and Janine. Thank you so much. We had, and Mary was kind in her introductions, but she also was driving in this particular piece. And so wanting to acknowledge that this has been a strong area of focus and interest in the association and also in support of you all as members in these discussions. And so, and I've been along for this for a few years with you all and just really enjoy being here to help you support it. And saying this, when we're doing the introductions, you know who we are. We'd love to hear from you while we're talking, through this discussion. We'd like it to be an engaged conversation. So we'll be pausing throughout parts of the presentation itself to give you time to send messages in. Taya has graciously agreed to keep an eye on that. So if you have thoughts or questions that you'd like to throw and ask out, we'll be more than happy to entertain and talk about those throughout today's discussion. So it's really an opportunity for you to hear and learn as you're thinking through managed care practices and what does it mean for your systems and the members that you support, but also how can you move forward with it? And hopefully this information will provide you with exactly what you need as in being informed in these areas. So the next slide, we're talking about this national scan. And in this presentation, we're really synthesizing the scan itself that was done on Medicaid managed care practices that particularly impact people with intellectual and developmental disabilities. It focuses on how states structure managed care, how they include people in managed care, the policy logic that's been behind this inclusion practice over the decades, how the different approaches are that they do it, and what are the emerging practices that are going to lead to future driving system changes? And how can you think about that as you're moving forward as well? Next slide. So we were talking about, how can this help you in its purpose? But it's really a one-stop document that helps document the state of individuals being supported in managed care practices. So this can identifies key policy drivers. It also outlines stakeholder concerns and implementation challenges that have shaped these types of models over time. It will also highlight best practices for some of you all in states and also shows that the state's growing reliance is also on managed care structures and using those to support a more holistic, coordinated system of support. And so we're going to explore today how the managed care systems are structured, identify these types of responsibilities that plans hold that you can lean into and leverage as a state, and then also outline to you how other states are moving forward to not only balance system accountability, but also ensure that the supports are disability driven and person centered, as Mary was mentioning earlier. Next slide. So why does it matter? In some places, and I know there are states where you may have managed care, but individuals are carved out for LTSS. And we're going to talk about why this matters, and in particular, from the context of an overall health perspective, not just LTSS, long-term services and supports, or HCBS, home and community-based care. Why does this matter? Next slide. So historically, as you know, disability services have developed separately from mainstream healthcare models in using managed care. As managed care has become a dominant Medicaid delivery model, it now shapes systems that really weren't initially designed for capitated or risk-based arrangements. This is especially important now as states are now using managed care to not only cover primary and acute care, but also behavioral health care, and also moving towards home and community-based services. So because of this, now coordination and understanding how these models run, how they play, are going to be essential for you as state operators to ensuring that optimal care coordination is continuing to happen across these settings. And as we know, Medicaid continues to be a primary payer of long-term services and supports. And as we see more migration of that into managed care models, this is going to become more and more important. Next slide. Demographics. We still see a modest growth of individuals with IDD, about up to 7.7 million individuals living in our systems. And as I've talked about before, about 50% of them are in your systems in some point, time or another, especially in Medicaid. Acknowledging that while children do remain the largest subgroup, there's a shift in our demographics towards older adults with intellectual and developmental disabilities, and it has significant implications for Medicaid financing, provider capacity in supporting them, and those coordination expectations we were already talking about, particularly for families as they age out of caregiver roles. It's going to be more and more important to pay attention to how these systems are supporting people. Next slide. This is not new to you. You already know this, that people with intellectual and developmental disabilities have complex health needs. They have higher rates of chronic and preventable conditions, and I'm going to just outline a few of those for you here. They are 30 to 50% more likely for individuals with Down syndrome to develop Alzheimer's disease. they're 2 to 3 times more likely to have diabetes, obesity, and heart disease. 50% of individuals with intellectual and developmental disabilities have gastrointestinal disorders, including chronic constipation, and we're all familiar with UTIs. Also, up to 25% of individuals have epilepsy, behavioral health conditions, and compared to the rest of the population. So it's really important to pay attention to their acute and primary care needs. These health patterns are what we are just talking about and score this importance. But by paying attention to them, it can also help avoid crises that could have been prevented. And also to help prevent people from going to unnecessary ER visits and things that can be traumatizing and hard for individuals and families. It can also help to ensure timely preventative care that's needed. Effective care coordination is important, as well as aligning with behavioral health. States are now leaning to managed care to often justify this as a way to improve or coordinate care in these particular areas. But it's only successful if it's designed with disability competence in mind. And just to let you know, if you're curious about the statistics that provided, you can find them in the environmental scan report. There's a huge resource list that you can find and avail yourselves of it. But just to give you a quick heads up about where some of those came from, we're pulling them from the Kaiser Family Foundation reports, CMS reports, and also National Institutes for Health reports, just to give you an example. So it comes from all over. It's very well studied and known. Next slide. Medicaid is a primary payer in the system, and 66 million human beings receive supports through Medicaid, 78% of the population. So it's really grown the number of people receiving their supports through a managed care model. At the same time, we're seeing a significant increase in service spend in long-term services and supports, exceeding $60 billion in 23 alone. And this is largely, in fact, due to federal policy direction and disability rights principles driving more people receiving supports in their homes and communities. And while this is great, people also see the large growth in services and start to think of managed care as a mechanism, so to speak, to help manage growth or anticipate it while maintaining quality and oversight. So states, as their budgets start to get larger and grow, start to lean more towards managed care principles. Next slide. So for many families, navigating Medicaid feels like just managing several disconnected programs. And that doesn't even begin to account for the people who are actually eligible for both Medicare and Medicaid services. So states are, as we said earlier, are starting to really rely on other partners, program partners, to help them with centralizing accountability for coordination. And that's where you're also seeing the growth in managed care. Next slide. Now, we're going to be moving into the next section that talks about how managed care evolved. And some of you may have been here through this whole experience, and some of you may be in the middle with some experience, and some may be brand new to this. So hopefully this is helpful to you. But before we jump into this section, just want to check and see if there are any thoughts or questions. Not sure if there are any yet. Okay.
Erin, I don't see any yet, but I did put a reminder in for folks to use the chat pod to give us your thoughts or to ask questions.
All right, perfect. Thank you, Taya. All right, so we're going to move on into the evolution of managed care. So we're actually calling it the path. And then the next slide, for individuals with intellectual and developmental disabilities. Really, the exploration of managed care began in the late 80s in states. And it initially focused on children and low-income adults in the Medicaid program. People with intellectual and developmental disabilities were deliberately excluded from Medicaid managed care for literally decades due to concerns about appropriateness of care and risk. They were quite frankly concerned their care was going to be cut. And there were some initial issues that happened with managed care that had led them to this justified belief. So managed care systems just weren't as familiar with the needs of individuals with intellectual and developmental disabilities. And while the managed care systems now serve a majority of the Medicaid clients, people with intellectual and developmental disabilities are still followed a different trajectory, a slower path, which is great. A longer period of exclusion, also very cautious and gradual inclusion when it did happen. And even to the point recently where you're starting to see specialization and targeted interventions and work tied to serving people with intellectual and developmental disabilities. So definitely has been an evolution in this world for you all. Let's talk about the first phase. Phase one. That's when people with intellectual and developmental disabilities, in the next slide, were excluded primarily from the 1980s through the 2000s. This era prioritized stability of disability services. A big focus is, let's not mess with what is already working. I heard that a lot. And in some cases, states were dealing with settlement agreements, and they didn't want to add managed care to the mix as well. So they favored keeping the service together as it is versus integrating it into a managed care model. Advocacy concerns strongly influence these state policy decisions, and some of you may have even been involved in advocating for that. And that was a good thing. States did so, however, as you could see over time, start eventually including people with intellectual and developmental disabilities in for acute and primary care services. And we're going to talk a little bit more about why families and individuals were concerned on the next slide. So what led to that? Those drivers that led to exclusion. One, people have complex lifelong supported needs. A lot of people were initially added to managed care were seniors or people with physical disabilities, but it was seen that people with intellectual and developmental disabilities were just more complex and just weren't ready yet to include. Also, as we talked about in the last slide, managed care companies had very limited experience with supporting individuals with these unique needs. And they were concerned, quite frankly, about having networks that really could serve them and meet their needs because a lot of people, and that was my experience in Virginia helping to develop this, they did not necessarily have the specialists needed to include people. We could talk a little bit more about that later. So the traditional managed care models were just simply not designed initially to provide the intense level of coordination to address people's challenges, their behavioral needs, or their long-term services and supports. So there were lots of good reasons why they were excluded. Next slide. Now, there were some states, and this is just in general, adopter of managed care. The first one that really brought a lot of people's attention was Arizona. I remembered starting my job at Medicaid in 95 and being tasked with looking at Arizona's model. Everybody was interested and curious about it. And they eventually included integrated acute and LTSS, and it was through an innovative 1115 waiver. And it has continued to operate under this. But part of the reason they've been successful is that they have strong oversight of their system. Started off that way and continue to maintain that. And I just wish to bring up, though, that Arizona at the time was an outlier for many of us to look at and to follow, but it still took many states, including Virginia, a while before we were ready to dip into the managed care scene for people with intellectual and developmental disabilities. Arizona will be presented in more detail later in the presentation. Okay, so the first phase we talked about, why people are, when we were talking about the exclusions and why it just started where it did. The second phase is around 2010, beginning there. You started to see interest at the federal level in integrating care with managed care models. So you saw federal policy drivers start to encourage states, even push states to move into looking at this as a viable option. So it played a significant role in helping states to think about that. Even when families and individuals and community partners said, let's be cautious, let's be careful. And you could still hear that even in the federal policy changes. For example, in the duals demonstration, they specifically said, except for one pilot, do not include people with intellectual and developmental disabilities. It was almost explicitly required in the very beginning stages of that demonstration. But as changes come, as the program grew in Medicaid, as home and community-based services continue to grow, costs were rising. We talked about this earlier. The accountability pressures continue to mount on states to have a focus on whole person care and an interest in quality oversight. And in the next phase piece here, we're talking about is that we see this, that's what we're talking about, the rising costs and accountability, and also making sure that people are really getting the care that they need. So they're starting to spend more time thinking about that and look and what that looks like and how states can measure that. And so the next slide starts to talk about what are those safeguards that states were starting to employ. And with federal support, I might add as well. So these safeguards were initially put in place to ensure that managed care did not undermine service quality or rights of people who use the services or their families. And also, I want to add in here the providers who support them as well, because it went from states providing services and paying providers to states and providers, and the provider and a managed care system. So almost a trifecta right there. Now you're seeing states in this period of time requiring managed care systems to contract with providers who were experienced with people with intellectual and developmental disabilities. We even did that in Virginia, just as a highlight. Worked with, huge shout out if the Virginia team is on the call, worked with the Department of Behavioral Health and Developmental Services to identify who those critical specialists were to make sure they were in the networks of these managed care companies. Also, states were really interested in making life easier for individuals and families. For example, by having a unified grievance and appeals process, so you only have to do it once. And also how spending more time on how you're going to monitor and evaluate this system, especially when you're talking about long-term services and supports. So very important key factors here. Next.
Karen, can I interrupt and see if you can do a sound check?
Oh, yes. I'm sorry. Is this better?
Yes, it's got a little soft somehow.
It kind of pops off. All right.
Yeah.
I'll do my strong voice.
It's much better now. Thank you.
All right. I'll do my strong voice and just hope it doesn't. So apologies if people feel like I'm coming across booming, but I want to make sure you hear me, and we've had a little bit of sound issues. So thank you, Taya, for catching that. So we went through the first phase and the second phase, and now we're looking at what is the landscape like now in 2026 after 2010. How are we looking at this point, and where are states in their current processes? Next slide. Regional managed care is a predominant factor now in the service delivery system. As you can see, 42 states plus DC now operate this. Even when LTSS remains carved out, it's still a big component of all state programs now. And we're seeing an increasing number of people with developmental disabilities and disabilities in total entering the program. I call this the wide and deep factor. So you see managed care across a good number of the populations now statewide in your states, maybe not just pilots in little areas, but not only are they statewide, but now they're covering other unique populations, including individuals with intellectual and developmental disabilities. So that's where you see that. That's why this is the predominant component that you see is that get receiving services in acute and primary care settings through managed care models. And those are the ones that happen the most now. And that's where, to be honest, states tend to start. Next slide. Now, this is interesting. So when we started to look at this and start this environmental scan, Mary and Taya and Janine and I were talking, and we realized at this point that the latest data model that shows people with intellectual and developmental disabilities and how many they are and where they are located, what the states are doing, has not been updated since 2018. We've looked. And even the groups that tend to do this, like Kaiser Family Foundation, are unable to provide updated estimates related to this. Part of this is due to the lack of consistent data that complicates cross-state comparisons and evaluation efforts, and is also tied a bit to a change in federal reporting, CMS reports on enrollment, which no longer includes this level of specificity. And you're seeing more and more of a reliance on what states are doing, to state level analysis, which continues though to still advance this model and supports, but it's just not, hasn't been collectively analyzed before now. And when we were taking a look at that. But you can see here that it's been dated back to 2018 since we've actually seen meaningful data reported on the number of people with intellectual and developmental disabilities being served in the system. Next slide, please. Now, before we start into the framework, I wanted to double check to see if there were any questions about the progression of managed care, and I'm going to double check and see if there's
Yes, Karen, we do have a question. Has managed care had an impact on states' wait list for home and community-based services?
So some states have tried to leverage managed care as an avenue to help engage people to receive services. I believe Tennessee leveraged that approach at one point to say, if you join into managed care, then you don't have to be on a wait list for X services. But there are still waiting lists at this point related to that. I've not necessarily seen a definitive drive. Taya, you may have some thoughts on that as well, but I'm not necessarily sure it's helped with the wait list as much. It's more about
And I think it goes back to, Karen, the differentiation that you are making and that we've been feathered in through and touch on in the report is the difference between managed care covering acute and primary care, some behavioral health, and separating that from long-term services and supports or HCBS. So that's where we're not seeing the impact on the waiting list because that's LTSS or HCBS and not the managed care framework that we're talking about. And then there was another question. You mentioned oversight in Arizona, and by whom?
Oh, we'll be getting into detail with that coming up, and excited to talk about that, and maybe some shout out to the team who are doing the oversight here in Arizona as well. So
okay, so we'll put a pin in that.
More to come. Yes, thank you, Taya. All right, so now we're looking at the framework. So first we talked about the evolution of managed care, and now we're talking about how do states actually leverage managed care in supporting your very unique population. And we looked at it through 3 different categories that you'll see here. And they're organized to show just how diverse state approaches are. And we're going to be highlighting their designs and the pros and cons of them. And so you can better understand where states are. And just also to let you know, there's no one right or wrong process here. All states are at different stages and levels, and each one is perfectly fine to meet your state's needs at where they are. So it's a journey, not a destinated path that has to be there. But it is important to know that there's a larger lion's share of individuals with intellectual and developmental disabilities receiving acute and primary care in the first category. That's where states usually start. All right, now we're going to start in talking about acute and primary care and managed care. Next slide. And then you can jump on into the next. There we are. All right, so see that stethoscope. At least 29 states, plus Washington, D.C., enroll individuals with IDD into Medicaid managed care for physical and behavioral health services. Now, they can either do it in a mandatory or they sometimes do it in voluntary enrollment approaches. So it's not always required. It depends on the state. And this model, though, reflects a very cautious approach that states take when they're leveraging managed care in their strengths in medical care, while they're still preserving disability service systems in fee-for-service. Next slide. Advantages and disadvantages that we'll take a look at here. First piece, that's what we were talking about. People just do not want people being disrupted with their long-term service and supports needs. And the way you see it, it took a long time to build this system and get it here, and people are very concerned. We don't want a managed care system to disrupt that, at least that in perception. It allows them also to build managed care experience with IDD populations, those health plans, those managed care groups, because you're targeting specific provider groups that support these individuals and making sure that they get those supports. And as I said earlier, it's often seen as a transitional model. I called it the soft kitchen start in Virginia, or a toe in the water, so to speak, as states venture into managed care. But there are challenges tied to this too. As you do these little steps into managed care, there is still fragmented accountability because it's not one entity supporting for all needs. And the coordination still relies heavily on relationships versus a structured approach, as you would see in a full risk managed care model. Reasons, just pointing them out. Next slide. The managed care infrastructure itself can improve continuity of care when it's properly designed and monitored. So you can see here, you can also monitor health outcomes. Those health outcomes we were just talking about that people uniquely experience. There are measures called healthcare effectiveness data and information sets, or HEDIS, that all states actually require managed care companies to report, that gives a nice snapshot on how they're doing in supporting people in their acute and primary care needs, even behavioral health. So that gives the ability in this area for a state, and that includes you all too, to be able to monitor and see how your members are doing through managed care. Some things that you see related to this, as they're able to better monitor people's primary and acute needs, you do see a reduction in ER visits. You do see better care and follow-up after hospitalizations. So those are things that you see with other populations as well, also benefits people with IDD. Next slide. A big piece, I was just talking about the quality and mentioning quality and oversight with the HEDIS measures by using these standard medical quality measures that I just talked about. But not only that, states are also, because they're so medically, and I would say that a medical model, people have been very concerned about managed care being a medical model, right? That they don't understand the unique social needs of individuals. So while that can be true, you really want to take a look at their medical needs, and you've got these measures to look at, and they can be compared across the country. All states have them, so it's a nice standardized approach. Now, states are also, even though they may not have long-term services and supports in managed care, they are still starting to use supplemental LTSS related indicators to look at service delivery. such as leveraging the NCI IDD, which I'm thrilled to see that is in 48 states are using, plus DC. So when you're thinking about quality and oversight as a state and how you want to advance and learn more and supporting your members, you can always leverage or take advantage of what you are already doing and require it, or even just take a look at a subset of members in acute and primary care. So leverage what you have. Next slide. There are also nuances with provider network expectations. I love these parts. We talked about the standards for primary and specialty care because people with IDD tend to see more specialists. They need to see, we talked about GI doctors, but they also see psychiatrists, behavioral, behavioral support professionals, and also neurologists and other specialists that maybe others don't see as much. And then there's an expectation now for these providers to be disability competent, especially for people with IDD. They will even, states require, put additional provider requirements for learning this to be a part of the network. And also states are moving into, it's called tagging, where they will require a health plan to include in their provider directory providers that support unique members of individuals with developmental disabilities. So this is supposed to help reduce people's, if they're having issues with accessing care, it helps them find the specialists that they need, because if they can't find them in network, they will help you get them out of network as well. So that's a really nice piece. Next slide. If you're curious about which states are doing what, here's an example of that for you. And when we're talking about mandatory enrollment, we're talking about when people are required to use these plans for medical and behavioral health services. Examples include Arizona, Tennessee, Texas, Virginia, New Mexico, and New Hampshire. And then you have states who say, well, wait, we have managed care here, but it's your choice. And you'll see states listed here: Colorado, Florida, Minnesota, Rhode Island, and Wisconsin. And then, of course, there's some that even target regional or program-specific variations where they actually reflect local provider capacity and allow for incremental implementations. And some states that are listed here, one of which I want to shout out to as well was New York, that recently did a duals demo unique to people with intellectual and developmental disabilities. So you're seeing lots of trials and changes coming where people are just testing the waters to see what works best for their state. Next slide. And a nice example here is Pennsylvania. And if you want to see other state examples as well, they're all highlighted in the environmental scan. So encourage you to check out the report itself. But an example referenced here is Pennsylvania, which illustrates the strengths and coordination challenges of carve-out models. And we also have one carve-in model for Pennsylvania, but they do tend to support people with IDD through a partially integrated managed care structure. And you can see their program called Health Choices is mentioned here. Most of the Medicaid beneficiaries, including people with IDD, receive acute and primary care services through their managed care organizations in this model. Behavioral health, however, is managed through separate behavioral health managed care systems in their communities that are carved out and, as I mentioned, operated by the county-based systems. So as you can see, it varies and it can be different. And it may be managed care, but it may be by service versus like population drive, right? And I did want to mention here, Pennsylvania has a unique program called ACAP, the Adult Community Autism Program, which is fully integrated for these adults, but it's just limited in 4 counties. So as I was mentioning earlier, you may see some statewide programs like Health Choices, but then you may see some smaller, nuanced ones that are really targeting people with more unique needs. So as a result, you can see where Pennsylvania is setting themselves up to do broad support in acute and primary care services, and also targeted support through long-term services and supports in different ways, and behavioral health, which is really important. And that just to also want to mention here, the 8CAP model is a voluntary program through a state contracting authority. Okay, now we're going to move on to the risk integrated models, which are full risk. That means a state brings on a company to do the comprehensive full risk piece on the next slide. Okay, there we are. So the comprehensive full risk managed care models for individuals with IDD are really reshaping Medicaid integration. So states are starting to require services to be streamlined. They're emphasizing person-centered care, and they're prioritizing employment and community participation, which is great, quite frankly. As more states start to adopt and refine these kinds of models, it's going to be so important to monitor regularly with evaluations, collaborate among community partners, and that includes people with lived experience. It's really, really important. And so all these policymakers are working closely and more in alignment to help design these models. So, but the full risk, having said that, full risk managed care still represents a major shift in Medicaid policy, which is really aiming to deliver the entire spectrum of health and supports through a single accountable MCO. And under this model, they are responsible for coordinating primarily all of the care that somebody receives if it's full risk. The design approaches to streamline the care, better predict costs for services, and provide that single point of accountability that we've been talking about earlier. Also, how to enhance quality and improve outcomes for people by monitoring all these measures that get reported to better inform you for how individuals are doing in your system. Next slide. So what are some of the key elements that states include when they're doing full risk managed care? And we took a look at this and saw there were several key core pieces. I'm just going to highlight for you right here. One is that it's an integrated benefit package. So states require IDD HCBS services directly into their MCO contracts. This ensures that they receive the full continuum of care under one plan. And they're also accountable as well. That's a big piece. With disability competent provider networks, we spoke about that already, but they require the plans to recruit and maintain networks that are skilled in supporting people with IDD. Specialized care coordination, states require specialized training to understand people with IDD and their unique needs. And they also set low caseload ratios as well to make sure that those care managers can actually really meaningfully support people. They also have employment first initiatives. Love seeing that piece where they require MCOs to promote competitive integrated employment for their participants. And they leverage a whole different group of things to make sure this happens. They do value-based payments, and sometimes they do incentives, financial incentives for successful outcomes. They also strongly support and require person-centered planning. Those requirements are embedded in the contracts to make sure that participants and families are heavily engaged and involved in decision-making in their care. Plus, we've already talked about quality and safety oversight, where the states are monitoring service timelines. They monitor the health and welfare safeguards. They also require, and you're used to this, robust incident reporting. So that shifts, they still have to provide all of that as well. Next slide. Several states have pioneered comprehensive full risk managed care models for our population that we're talking about. And this slide gives you an example of them. And I'm just going to read off a couple of them, but you can have this for your reference later. A couple that we haven't spoken of before, are the North Carolina's Taylor plans, which offered integrated behavioral health, long-term services and supports, and IDD supports through a single managed care entity, where it really does emphasize person-centered planning and transitional supports. And also more recent one here is Ohio Rise, which went live in 22, which focuses on children and youth with complex behavioral and developmental needs, including people with IDD, coordinating services across the system to improve their care. So here's some nice examples, and this chart can be found in the environmental scan. Next slide. So there are also states, when they leverage managed care, they are committed to improving access, quality of care, independence, and community inclusion, like we were talking about, is a growing emphasis, getting stronger and stronger as they become full risk. They are increasingly tying payments states in areas of outcomes like this to make sure that the health plans actually do what is required or expected of the state. Think about when states are moving towards this, you have a role. You could be involved in this and helping them as they're designing these models to give these considerations if you're not already doing it. Some states, as we just saw a highlight of some, but there are opportunities for other states who have not given consideration. Hopefully this will help give you some food for thought moving forward. Some other things you see here too, focus on accessibility, just making it easier, like we said, for people to navigate the system, and also expanding involvement, including people with lived experience in designing, implementing, and being a part of these models. Next slide. So this is just another informational slide for you to have that lets you see which states are integrating HCBS, doing employment first practices, etc. And you can have this for future reference. Next slide. Another highlight is Florida. And Florida actually represents more recent movement towards comprehensive IDD focused managed care. As you can see here, it's called the IDD Comprehensive Managed Care, or ICMC program. So they integrate the full array of services, including Florida's IDD waiver, iBudget, into a managed care framework for people to receive care. So it also includes, you can see here, some examples of what they have in their model. Notable contract features, they have very specific IDD care coordinator ratios, 1:18, just in case you're curious. They have employment first requirements, and they also have strong requirements about timely access specifically to behavioral health supports, crisis, and family services and supports, which is really great to see. They also specifically call out needs and requirements tied to people with intellectual and developmental disabilities in their contract. So it's not that you just assume people with IDD are included in it. They actually call out people with IDD in their contract, which is really nice. Hats off to Florida if you're on the call. Okay, next slide. So as we're talking, we'd like to talk about the challenges and benefits of these models. Benefits are unified accountability, one company that is accountable for for predominant needs of individuals that they support, and also making it easier for people to reach. So a managed care organization, they should have a care coordinator to call who can help them with any of these needs and support them on this aspect. Now the risks are when you go into full managed care is that it's very complex to launch. It's very complex to develop as well. It takes a good 2 to 3 years with meaningful input with people with lived experience to implement these well. And that involves steady monitoring of progress, including by people with lived experience and their partners in the community. And it requires strong capacity, a state that still keeps a strong eye on quality outcomes, and monitoring those contracts. In a lot of cases, they can leverage you as supports in monitoring those contracts and those outcomes. So I would invite you to give that some thought if you're not already involved. We're going to pause here. Oh, Winslow Woodland asked a question. Would full risk take on the state function of eligibility and authorizations? And the answer is they take on the full risk for service authorizations. So they maintain provider enrollment, they do service authorizations and claims payment, and also monitoring quality of services delivered through managed care. But initial eligibility determination is typically done by the state or its partner. And in some states, they still manage their eligibility redeterminations with community and local partners. Some allow the health plans to review to see if person continues to meet for waiver services for eligibility. But ultimately, it's still done for us in Virginia at the local level, who your eligibility contractor is. That doesn't tend to change. But if they see level of care needs change, then they'll report that. So there are still some functions, that's a great question, Winslow, that are still maintained by the state. And if you do, as a state, have managed care, CMS requires that states monitor these areas closely. So they may, for example, they may allow the plan to do the authorizations because they're at full risk, right, for the care, but the state will monitor a percentage of those authorizations to make sure that they continue to be appropriate. States also have teams that monitor quality. If people have concerns or questions, they can call and have those pieces. So that's a good point, that there are still administrative responsibilities managed by the state. And I would not strongly advocate that a plan takes over all roles and aspects. And I dare say the federal government wouldn't either, and the state. So great questions to ask, keep them rolling, and love hearing them. Thank you. Next slide. Oh, and before we pause, any other questions beyond that on this particular area before we talk about the latest reiteration over the last decade, which is Medicare, Medicaid alignment, these two programs?
Karen, I don't see any others, but again, encourage folks to use the chat to either comment or ask questions.
And I do wish to say this, there is no such thing as a dumb question in this world. It's just a question because it's so complicated. And this is an excellent area to just ask away. And if we don't have the answer for you, we promise you we'll get it for you. So please ask. We love hearing the questions. All right, so now we're going to talk about duals and dual eligibility. Next slide. Why does it matter? Well, as we talked about before, a majority of individuals with intellectual and developmental disabilities are going to be dually eligible for Medicare and Medicaid services. And you have the ability, even if your long-term services and supports are carved out of managed care, chances are you have people with IDD who are getting managed care for their Medicare covered services. And so you have the ability to influence, how we were talking about earlier under Medicaid. You also have the ability to touch on and receive that information on the Medicare side as well. And that's what we're going to talk about. Because as difficult as it is to manage Medicaid, imagine adding Medicare on top of it to a family. And it can be surprising, shocking, and just, how to navigate this. So the goal is to make it easier. For example, one card for somebody to use for both programs, even one number to call, still to help manage that coordination of supports to make life easier for people who receive both. And you can do this. Oh, Taya also provided, NASDDDS has done some extensive work on this, on dual eligibility. There is a toolkit that contains all sorts of wonderful information that you can receive for your members, your staff, and also your team and your community partners to explain dual eligibility, what it looks like, and how you can share information, especially for individuals who may not understand it as well. Beautiful video about that, especially for your community. So take a look. All right, so the next slide, we're going into the key elements that states, so when these programs are called dual special needs plans or DSNPs, want to play in your state and support your members, they have to get a contract with you. I'm not sure if you knew that. A lot of states know this, but in your world, in your system, you may not have been involved in these. They're called state Medicaid agency contracts or SMACs. And they have to get a signed contract with a state every year in order to operate. And through these SMACs, you can leverage all kinds of requirements and expectations and even ask for really helpful things for your members. So, for example, you can have enhanced coordination standards through the SMAC contract, and they have specific requirements unique to people with IDD through these agreements. You can also require, as I mentioned earlier, those integrated member materials. Imagine one card to use, making it easier for people to navigate. Even the materials that they have to use to look for a provider can be easier, such as the one below, provider directory tagging. We already talked about this. You can actually require these companies to note which ones serve both Medicare and Medicaid, and even in particular, unique needs of specific groups. There are also other different types of requirements that promote more integration, such as grievances and appeals. It shouldn't have to be a problem for that person, shouldn't have to try to figure out, oh my gosh, which company, which program paid for that hospital? Was it Medicare? Was it Medicaid? All they need to do is if something wasn't covered and they need to appeal it, they just need to make one appeal. And so one appeal takes care of both programs. And that, like I said, this is really supposed to be easier. And this can all still be done even for fee-for-service members. So just keep that in mind. Next slide. So for states that have adapted this as Medicare, Medicaid, I'll say dual alignment in the systems, you can get examples right here and we wanted to really kind of point out more for you those states that they're still in fee for service, but they are leveraging these models to better receive information on the types of care their members are receiving, which can then help inform them on what types of changes they want to make or requirements to make in those SMAC contracts. So you can see nice examples here, and kudos shout out to all the states that we've been recognizing lately. You all are doing a really great job. And these are the foundational strategies that states are using. So when we give examples like this of the states, please note that the examples, the processes we're talking about robust care coordination and the unified processes are all are universal to these states, all states. Some of them just do it a little bit differently, but they are all following similar paths. Now, in some of these states, there is diversity in the approaches for how to provide this information to unique populations. And so you can, I just wanted to acknowledge that some states say this is for everybody. Some states even say, we want you to provide this uniquely to people with IDD. You can do that, just to let you know. It doesn't just have to be one size fits all. Next slide. All right. Got that beautiful cactus here for Arizona. And we've agreed we were going to talk a little bit more about Arizona and its unique feature. And this is part of the unique feature. There was a question of who manages this, and this is a beautiful, beautiful way that this is designed. Arizona's long-term care system is managed, actually, the managed care model is handled by their Division of Developmental Disabilities. And it's really fascinating. So just to go show you that it doesn't always have to be regional managed care, it could be administered in different capacities or led by different organizations or not just Medicaid, right? So it's really beautiful to see this example, one of the earliest and clearest examples of a full risk managed care model in place. They really are responsible for an integrated care package, and it has operated for decades under this authority and really does still stand out as a really nice example of an integrated care model. And just a few examples of what they do. They have a separate contractor, as I mentioned, that provides unique supports and services to people with IDD, and we just gave a shout out to the division there. They also have requirements for uniform encounter data. Encounters is reporting and managed care for claims, service delivery claims, and quality reporting across all benefit domains. So they provide that monitoring and oversight on quality. They have detailed incident reporting requirements. They have mortality reviews. They do health and safety requirements specific to HCBS IDD settings. So really, really nice examples here. And also, I love the contract examples where they talk about scope of services and special populations and note that the DDD contractor is responsible for the full continuum of care. So very specific language tied to this group of individuals in Arizona. Nice shout out to Arizona. Thank you for leading the way and a lot of things for us. All right. Next, we're going to be talking about cross-state leading practices. As we've discussed earlier, the states are using a huge range of innovative approaches to advance the evolution of these managed care models for people with IDD. And because of this, they've been really focused on specific strategies that help refine them by emphasizing person-centered planning, as you can see here, quality of life outcomes, provider competencies, and robust accountability measures. So the next slide, oh, you've got this right here, keep it here. We'll explore these leading practices, and also we're going to give some more state example, and then we're going to talk about national trends on this piece as well. So in these particular areas, as I mentioned, these are the key safeguards that states are doing. And that's what we wanted to show you is what are the themes that we're seeing across that. So we've seen themes and elements included in models, but what are the really successful themes when they're including people with intellectual and developmental disabilities? And you see these here. And I love, especially the governance by individuals with lived experience, which I do want to shout out to the federal government at the time in the like 2010-ish later, started really getting involved and requiring states to involve people with lived experience. And you as states have taken that and just run with it and seen some beautiful examples of how you require that in your contracts, and we'll talk about those. So we're going to go through these each one real quickly. The first one is specialized care coordination. And when we talk about it on the next slide, you'll actually get an example of two states that currently do this. So if you're curious and interested, you can go to the report, and also there are references on that. So next slide, please. Here we go. So as we mentioned, there are states that have very specific training requirements for individuals with IDD. As we mentioned, they have smaller ratios and they have lifespan and family-centered focus. So stepping away from that totality of that medical model to being more social and actually recognizing the lifespan of a person versus just what are those medical needs. Couple of states we highlight here. We've talked about Florida. We've also mentioned Ohio. But wanting to touch this is one of the most consistently cited practices across states for this model of care. So it's very important. States do recognize its critical nature in helping people with navigating these complex systems. Next slide. Like I said, my favorite one, governance by lived experience. Actually, I love all of them, but I just, it's really nice to see this enveloped in that people who actually receive and use the services are a part of this. That it really, to have really effective managed care, you require the perspectives of individuals with disabilities and their families in the decision-making process, not only in the supports they receive, but in the design of the program itself and then how it's going. And is it really providing what people need? And then how do you change it when it's not? These are really important to ensure transparency because of those concerns we talked about in the very beginning about rationing care, people not getting what they need, and that basically plans are just out to make a ton of money and not really care for people. These types of governance practices help to make sure that people's voices are truly heard. And we have examples for California and Tennessee. Shout out in Tennessee on this point, where they include at least, they require 51% representation from members and families on their advisory boards for managed care. So very exciting to see those pieces. And also California, their self-determination program, they leverage local advisory committees. So beautiful ways. Every state's doing it just a little bit differently, but it's still just as impactful. And you can too with the way that you leverage it in your state. Next slide. Person-centered planning is also a very important key point. You know, you've been living and breathing this for decades yourself, person-centered planning process and practices, but it's really starting to move more into managed care. You're seeing it embedded as requirements in their state contracts. And so it not only helps define that, but it helps define that whole person-centered care where the person drives, not the plan. So this is really, really an important piece that we want to see. And then the next slide just gives you a couple of examples, again, of some states that are doing it well. There are other states that are doing this well, and so if we don't highlight you, it doesn't mean that you're not. We're just picking a few out of the report. Please see the report for other examples. And the next slide will show you Oregon and Tennessee as a person-centered practice examples. Trying to say, there we are. Thank you. And you'll see this on here. The Oregon's plan requires that person-centered planning piece and the annual reviews where the member is actively involved in driving. Same thing for Tennessee. So just giving you a feel for examples of how they're doing it. Next slide. Provider network competence, cannot stress how significant and important this is. You know this in supporting your members, that people really need to know that the networks contain the providers who can support them the best and in the most informed way. So directories that help people to actually know who these providers are and that the directories are actually real. So that's something we're working on as a system across to make sure these providers really do exist and that people can get to them in meaningful manner. So if the nearest provider for somebody is 5 hours away, that is not going to work. They're going to make sure that the plans help you find that support that's closer for somebody. If it's specialized and nobody covers it near you, they're also required to take you where you need to go. So, and we also have examples here of Minnesota and New York, where they require, for example, Minnesota, ongoing training for providers and periodic checks on the network adequacy. And in New York, in that demonstration I told you about, the duals demonstration, they did have the directories that were required to identify specific providers serving people with IDD. So all kinds of examples across the board. Next slide. Quality is an area near and dear to all of your hearts in the system. That you take this quality and that it goes beyond. So as we're seeing the themes, that it's not just those medical outcomes, those HEDIS measures that states are looking at, but you as a system are looking at employment outcomes, things that are meaningful to people, community participation, as much as they want to or desire in their plan, and use of experience of care surveys. NCI, I know I talked about this earlier, but states are really starting to learn how to leverage these to help ensure the quality side, how people feel about what types of services they're receiving and the care they're receiving. That matters just as much. And it's really nice to see states leaning on this, that it's the quality of life. Because if they have a high quality of life, then those other health, they may have a significant number of comorbid conditions. They'll still do better than somebody who's very depressed and is isolated. And I think you all know that as well. And it's really important to do that. Next slide. Wanting to get a couple of examples here. for you highlights of North Carolina and Texas, in particular North Carolina. Their Taylor plan has a framework that includes these quality measures that we just talked about. And it also includes, I love volunteer participation, where the people's independence levels are, and their crisis response use. So they're actively keeping an eye on that. And it's nice to see that they're spending more focused time. And it may be that that was just an area that they chose to look at. Another piece to mention to you, as a state, you can choose where your priority is. There may be a particular health issue you're seeing more in your state or just in prevalence, and you can target measures towards that. Every year you can change if you need to or look at and refine. That's the nice part about this. Texas, they also have metrics on service plan implementation, family satisfaction, love, and transitions. They're really watching to make sure if people say they want to, that they get to transition to independent living. So those are really great. And also shout out on Texas here that they're actually using NCI, it's AD, but it's still an example to compare MCOs and their scores related to people being satisfied with their care across plans. So people can actually see where people are happier among those plans. Next slide, please. And Taya, I saw that you're sending in a note out to people. So if there are no questions, we're going to keep going. Also, critical incidents, rights protection, significance. Plans are growing and learning a lot. They know about how to do some of this in the acute and primary care world. Definitely an evolution, definitely learning practice where you all as state systems are still going to be very involved in this practice and monitoring this and making sure rights are embedded, that trends analysis are monitored. Some great examples here with Massachusetts and Wisconsin that they have their own. Massachusetts has a special office that actually monitors this related to it. So it doesn't just have to be Medicaid or you guys, you can leverage different offices and different components to help spread some of this work out. And you can start small and then gradually grow too as well. In Wisconsin's Family Care Partnership, you see examples of their requirements for trending incidents and reviewing as systemic issues. Just love, love seeing the level of depth that they're requiring for plans here. Next slide. So still not seeing any questions yet, getting ready to moving into the home stretch here. About national trajectories. So where are states heading now that you've learned, you've heard the history of exclusion and inclusion now, the different types of ways states are starting to envelop people into managed care models, and then where are they going next? Next slide. So as you've just seen, states are really steadily advancing the role of managed care um, for people with IDD, recognizing that successful implementation requires very deliberate planning and strong support structures in place, and that the most effective approaches emphasize incremental rollouts. I cannot emphasize that strong enough. Phased in rollouts, and also robust engagement with self advocates, community partners, and specialized training that reflects the unique needs of this population. And then also, states are grounding their models in employment first principles. They have rigorous quality measures, and then also with incident reports too, as well. And then making sure people are meaningfully involved in the programs as they develop and run them. So on the next slide, we're going to talk about what matters most as well, those real determinants of success that we're seeing for states that seem to be, able to be successful in these programs, that you see an evolution into these disability competent designs, that this demonstrates a significant transformation from where we were talking about in the late 80s to now, that the strongest approaches still prioritize person-centered planning, high-touch coordination, and continuous quality improvement. And as we look ahead, innovation is going to just deepen even more through expanded service integrations, wider use of value-based purchasing models, and more sophisticated technologies like AI to help support care coordination, improving the kind of data that you receive out there and that's used to measure how care is received, and also population health insights going forward. So this is a consistent theme for these designs, the person-centered values, and transparency in oversight and monitoring. Cannot stress it enough. This is what's going to help improve equity for health and access to care, which is meaningful for people with intellectual disabilities and their families. Next slide. And the key takeaways here is yes, managed care can support people with intellectual and developmental disabilities, but it really depends on the design set by the state. And that's the beautiful part here, is that the design can evolve as you see it, as you're working with it, and it can evolve in a myriad of ways, of which examples are illustrated throughout this presentation and in the environmental scan. But it also states that, first and foremost, as you've always felt this, the quality of life of an individual, their autonomy, and the equity for them to receive services, gain access to it, and actually use it, and that it's meaningful to them is still very important. And that you, as state systems, are going to be those catalysts that help drive that and keep that as a priority in state systems. Next slide. This is the report. This is the environmental scan. You can see here where the link is provided for you to access the full report, which contains all of this information, including beautiful details, examples of state summaries and other themes, and just more detail for you to dive into if you're curious about it or if you have questions about it. Of course, the amazing team here at NASDDDS can always help you with any additional questions or thoughts you may have. And I'm going to turn this over to Taya to see if there are any additional questions by folks out in the system.
Not at the moment, but I will say that in addition to you being able to scan the QR code for the environmental scan, the full resource, I also dropped the link to it in the chat so folks can access that. And I'll take just another pause to see if there are folks that want to drop questions or comments in the chat. And while we're waiting for that, Carrie, I'm going to let you keep this on this slide rather than go to the question slide. Just Karen, thank you so much. Your partnership in this work has been wonderful. It's fabulous because you bring such a great amount of expertise and know-how, but heart to the work. You've been educational to not just our members, but to the NASDDDS team as well. And we just really appreciate it very much. Oh, and if you want to raise your hand to ask a question, we're also able to open microphones for that too. So anyway, Karen, just really enjoy the work and appreciate it, and looking forward to what we have to offer next. We're continuing our journey, as Karen said, in understanding Medicaid managed care and dual eligibility for people with intellectual and developmental disabilities. So stay tuned, more to come.
Thank you, everybody.
I don't think I see any additional questions.
Can I add one piece, Taya? Just
Sure.
to say to people, I'm smiling when Taya tells me this. When I was in Virginia when we first started migrating LTSS into managed care. And I admit I was one of the people that was pretty feisty about keeping people with IDD excluded, except I kept telling people they're already in. You
Mhm.
just don't understand. They're already here when they said you can't include them. I was like, but they're already in because they were in programs or services that weren't just exclusive to the waiver. And so that's a piece just to let you know to think about. You may not have full risk managed care, but there's so many opportunities for you. And we started paying attention to more of that. But hopefully this can help you think about that, whether you're full spectrum or you're still just beginning, there are all kinds of ways to think about this. And there's no right or wrong way. It's always just where you are and how you can best advance the needs of people. So thank you all for all that you do every day. Truly, it's a labor of love and appreciate you all. And hopefully we can have more conversations about this going forward. Yep.
Thank you again, Karen. No additional questions, so I'll just again express gratitude on behalf of the NASDDDS team and a special thanks to all of those who attended today. We hope you have a wonderful end to your week and a lovely and relaxing holiday weekend.
Take care.
Thank you, interpreter.